Hey everybody, welcome to today's webinar. We'll get started in just a moment, just getting a few things set up here. And I'll share my screen with you guys in just a moment. All right, well, welcome everyone today to today's PayDC webinar. Hopefully you can see my screen. Today we're talking about documenting diagnosis like a peer reviewer. I am Dr. Evan Gwilliam, and I am your presenter today. I'm the clinical director for PayDC. I think a lot of you have heard me speak before, and you attended a series of these webinars we've done this year. This is a CE webinar, which means that there will be a quiz, a survey at the end over some of the content so that we can get everything processed so that you get credit hours for your licensure. And we'll, so as we go through this, I will make sure to give you hints about what those quiz questions are to make them as straightforward for you as possible. And so just know that we're, a couple things to make sure you get the credits is you got to be here and be in attendance the whole time because we have a record of when you're logged in, and you got to answer those quiz questions that you'll get at the end. And then we'll forward those on. It usually takes 6 to sometimes 8 weeks, I believe, to get the certificate from New York Chiropractic College, who we partner with for the CEs for these webinars we've been doing for you this year. And I also want to let you know that you can submit questions, and I encourage you to do so actually in the toolbar that you have from GoToMeeting. So please don't be shy. Send your questions in, and I'll try to keep an eye on those so that I can see what it is you need to know to make this more clear for you. I've got a lot of information to share with you like I usually do, and this is going to be an action-packed webinar. So make sure that you stay in tune and focus, and let me know if I'm losing you or if I do anything that confuses anybody. This is me, and this is my background. Again, I'm the clinical director for PayDC, so I'm a chiropractor. I'm a chiropractic physician who happens to also be certified as a coder and as an auditor and a bunch of other stuff. And so that's what kind of qualifies me to share this information with you today. Those of you who attended the webinar that we did last month that I taught was also about diagnosis documentation, but took a slightly different approach. Today, we're going to talk about some coding guidelines, some rules from ICD-10, but we're going to focus mostly on conditions, specific conditions, and we'll talk about how those conditions can be documented in general. Again, this is not a PayDC specific webinar in terms of the software. If some of you have questions after the webinar about how some of the things I've taught can fit better with your program and what you're doing, feel free to reach out to me, and I can help with those kinds of questions a little farther in. Because we have to keep the content on education as opposed to the product because of the seed credits, we're going to try our best to do that. But I'm happy to help you with how it ties in to PayDC and how you can help you in your office more specifically later. And I'm also happy to do that in a one-on-one type basis. If any of you have trouble with audio, oftentimes it can be solved by switching from phone audio to computer audio or vice versa. In fact, more of the time we find that people have trouble with the audio from their internet connection. So switching to the phone seems to work the best. Yeah, that comment was for you, Sheila, because you said you're having trouble hearing me, which you probably didn't hear those instructions. Sorry about that. So glad you're here with me today. I think I've covered all the logistics. I want to jump right in because I do, again, have an action-packed webinar prepared for you and some great information I think you'll find helpful as you try to improve your record keeping and ultimately the communication you have with third parties, with other providers, with attorneys, with insurance companies who need to look at records. That's my goal, all right? I want to help you. So we are going to talk about the conditions you see at the bottom of your screen there in blue, where it says muscles, discs, headaches, pain, radiculopathy, sprain, strain, and subluxations. Actually, I think they're not in that order, but I have 7 different conditions that I sort of identified as the most common ones chiropractors see, and the most common ones you're going to use in a physical medicine focused clinic. And so I'm going to try to, hopefully we'll have time, we'll get through all 7 of those. And for all 7 of them, we'll discuss the 5 items in that list. We'll talk about what the code options are based upon looking at the code book and what they say. We'll talk about details that the coding book teaches us about those codes. And we'll talk about what I expect to see in your records and your objective findings to support that diagnosis, and the most relevant procedure codes to each of these diagnoses so that they are logical and make sense. And I'll give you one example of some documentation on some of these, on a few codes for each condition. All right, so that's our plan. This stuff is actually based upon a product I created for ChiroCode several years ago. It's these diagnosis and documentation cards that have most of the information I'm sharing in this presentation. And if you wish, you want some shortcut tools that are nice, these high quality cards, full color and all that, you can go purchase those from ChiroCode, and there's a coupon code at the bottom of your screen. I think it's 15% off or something. You can do that if you want to, but I'm giving you all the information today in the presentation as well. It's just if you want that other format, you can go check those out from ChiroCode, where I used to work. So I want to talk about some general guidelines first for just a few minutes, and then I want to get into these specific conditions. I just have a handful of guidelines here that I think are important to review. Some of you may have attended a seminar way back in the day when ICD-10 was coming to be, and in that seminar, you learned about some of these official guidelines. I mean, I taught these way back then, and we may have forgotten some of them. And I have heard and found that payers are beginning to deny little bits here and there based upon doctors not following ICD-10 guidelines properly. So we're starting to see it really kind of surface again, and based upon just simply not understanding the coding rules. So I'm going to go through a few of those with you here. I went through some different ones in the last webinar, which is recorded and on our website. So if you missed the one we did last month about diagnosis coding, it's called the diagnostic statement. The first half of that, or first third of that, I go over some guidelines there too. You may want to check out. So first, I want to talk about some guidelines from section 1B of the ICD-10 book. I'm basically looking at, you know, the ICD-10 manual, the official group of ICD-10 codes. And at the beginning, there's, depending on the font size, about 70 pages of guidelines, okay? And in section 1B, paragraph 3, it says that you should always code to the highest level of specificity. What that means is you can't leave off digits or characters from a code. If it requires 7 characters, use all 7. You know, if it only requires 4, then use 4. And then in section 4 of the guidelines, paragraph H, we are told that the first code that you should list is the condition or problem that's the primary reason for the encounter, the thing that's chiefly responsible for the services. And in the last webinar, I did go over a diagnosis coding hierarchy where I said which code should go first. But in general, the idea is that you should list first the codes that are the primary reason for the encounter. So if the patient has some little minor things that you want to report, that's fine. But the main thing should be first, okay? That's what you should list first as your primary diagnosis. So here's a little bit more specific guidelines, and these will tie into the conditions we're going to talk about a little later. In the official guidelines for ICD-10, in section 1B, paragraph 6, it says, code signs and symptoms when a related definitive diagnosis has not been established or confirmed by the provider. So in other words, if I have a patient who comes in and I think, gosh, I think they have severe disc degeneration and a herniation or something, but all I really know right now is that their back hurts, then you can code a sign or symptom. You know, if I think that their head hurts, I can tell they have a headache, but I don't really know the cause yet. I'm not really sure. I can't tell for some reason. I haven't confirmed it. Then this is an example of some signs and symptom codes from that chapter in ICD-10. They all begin with the letter R. There are other signs and symptom codes like M54s that talk about back pain and neck pain and so on. But these are some others you might want to consider. Again, I want you to understand you only list these codes when you don't have anything better. When you haven't confirmed the real problem, you're just saying, well, they have pain on their chest, you know, or their hip clicks a little bit. They're unable to walk very comfortably, but you don't really know why. Once you identify the cause of the difficulty in walking, which on this screen is R26.2, once you identify the cause, then you diagnose the cause, and you don't need to diagnose or list a code for the symptom any longer. And I'll give you an example of this here on the next screen. But these are just examples that I pulled out of this chapter of symptom codes that are found in ICD-10. So another guideline in that same section says, signs and symptoms that are associated routinely with the disease process should not be assigned as additional codes. So an example I came up with was, if you diagnose someone with TMJ, you should not also diagnose them with jaw pain because it's given. I mean, it's even in the description for temporomandibular joint arthralgia. It means they got pain. And so there is no need for you to code for symptoms according to the coding rules if you have already coded for a condition that includes those symptoms, okay? Then the next paragraph in the guidelines, paragraph 8, says additional signs and symptoms that may not be associated routinely with the disease process should be coded when present. So I tried to come up with an example for this. And so if I diagnose someone with sprain of ligaments of the cervical spine, and I think that's contributing to some nausea they have, that I believe that's a link. Nausea is not commonly associated with spraining the spine. So therefore, in that case, that symptom should be coded or could be added because it's not routinely associated with it. But I wouldn't code for like neck pain necessarily because I think it's pretty much a given that someone has a sprain or a strain in their neck wouldn't need to be coded with neck pain because it's a given, all right? And that's what these guidelines are suggesting. Only code the symptom codes when it adds something that's not already included in the other codes, and do your best to find a good definitive condition that really captures it if you can. Another guideline, section 4 of the guidelines in ICD-10 says that you shouldn't code for things that you're not sure of yet, things that are probable, suspected, questionable, that you're ruling out, or working diagnoses. They can do this in hospitals, by the way, when they order diagnostic testing, but not in an outpatient setting. So we are told not to code for things that we don't know are there yet. So don't code for a disc injury if you don't feel like you can be certain that they have a disc injury. If you feel like you can be, then go ahead. And if you believe the criteria for that is an MRI, then be free to have the MRI and don't code it until then. If you feel you can be certain that someone has a disc injury without an MRI, then go ahead and code it. You're the clinician. You decide when you're certain, okay? The guidelines don't say you have to have an MRI or not. That's up to you. A question that just came in from Vincent. He says, what about coding pain with a radiculopathy diagnosis? It's a judgment call there. I think that I would not code for pain when you code with radiculopathy, because I think radiculopathy implies they have pain. If you feel like it doesn't, and that pain needs to be coded separately to make it clear what's going on, then code it. The coding guidelines we just looked at just basically are saying it's not necessary, all right? So use your best judgment. Section 4 of the guidelines also have an interesting thing I think is relevant to chiros. They have told us that you should code all documented conditions that coexist at the time of the encounter or visit and require or affect patient care, treatment, or management. So that brings to question, so someone has diabetes, should I code for that as a chiropractor? Diabetes is not something chiropractors manage or treat. It's outside the scope of practice. So should I list the code? And I look at this guideline, and to me it says that diabetes coexists at the time of the encounter. If I feel like it's affecting my treatment, like they have diabetic neuropathy, and I'm trying to treat some radiculopathy, I think that I could list that as a relevant code to the case because it does affect the care that's being delivered. You might feel that it doesn't, or that might confuse the case. And you don't have to list comorbidities, but I'm suggesting this guideline says you could. Pregnancy is another one. You're not managing the pregnancy, you're not going to deliver the baby, but pregnancy is affecting the ability for their low back and pelvis, whatever, to heal. And so you want to list the code. A good one to consider there is Z33.1, which is a code that its description is pregnancy incidental. So if you want to report that the patient happens to be pregnant, that complicates the case that you're managing, then feel free to do so based upon this guideline. Z33.1 is pregnancy incidental. By the way, I looked it up and I couldn't find a code for pregnancy accidental, so don't use that, okay? But cancer, we don't want the payer to think that we're managing the patient's cancer or diabetes or pregnancy, but we may find that it's relevant to tell the story so that when they go back and claim that, hey, you treated them 20 times and we think you should only treat them 10, you say, no, look, I listed this other condition that coexisted that complicated the case, the cancer, the diabetes, whatever. Okay, so that's something for you to consider. It's not required necessarily. If you don't feel comfortable listing those codes, but just document the details clearly in the record. Make sure that's in the patient's history. If you don't want to code it because you don't take the chance that the payer is going to claim that you're trying to treat those things, A few more guidelines before we get into the conditions. An unspecified code should be reported only when it is the code that most accurately reflects what is known about the patient's condition. So don't use unspecified codes. And you may have heard this before, but I just want to reiterate it. Don't use them when you know something better. Only use them when it's the best you've got. Payers don't like them, okay? They're likely to deny them because it looks like you don't know what you're doing. Don't pick a specific code if it's not properly supported in the documentation either. Okay, we're also told that it's inappropriate to do a bunch of diagnostic testing just to pick a more specific code. Don't order an MRI if you don't think it's going to help with the care, just because you think you need a better code. Code for the symptoms until you have the information you need, or you determine clinically that it's medically necessary to order the diagnostic test. Okay, and those are all straight out of the guidelines. So here's an example of that. With unspecified codes, the reason you should never use them is because most of the time it's anatomic location. And it's really easy to pinpoint, say, it's the neck, instead of saying, I don't know where it is, you know? And so if you look at the codes for spinal stenosis there on the left, there's one that says unspecified spinal stenosis, and there's a bunch of codes that specify where it is. So just identify where it is. On the right, I have some extra spinal diagnoses there, and you can see that for each of these, you have right and left, and then you have unspecified. I mean, have you ever seen a patient who told you their knee hurt but didn't know which knee it was? Odds are good that you know which knee it is, right, when you have knee pain. So avoid those unspecified codes. In fact, when you set it up in PayDC, when you set up in your settings which diagnosis codes you want in your favorites list, I would advise you to leave off the unspecified as choices so you can't even pick them. Okay, and if you don't know how to do that, call support and I'll show you how to make sure you've got that set up. You shouldn't have unspecified codes in your diagnosis code selection list, in your favorites list that you use when you're setting up care plans and whatnot. A couple more guidelines. I think this might be I think of two more to show you. Chapter 13 in ICD-10 is the codes that begin with the letter M. It's the ones we use the most. And the guidelines for that chapter do tell us that if the patient has acute injury, typically you'll find those codes in chapter 19, which are the ones that start with S. That's where you find your sprains and strains, for example. And most of the time, recurrent and chronic conditions are found in chapter 13, which are the ones that start with an M. Just to give you kind of a bearing there, the difference between S codes and M codes. S codes are typically acute injuries, M codes are more recurrent or chronic. Now, a little side note here, if there's a multiple sites code available, then you're supposed to use it instead of listing several sites individually. Let me show you an example of that. If you look at spondylolisthesis, it's M43.1. There is a code there, M43.19, that includes multiple sites. So if someone has spondylolisthesis in one region, then you pick one of the other codes. But if they have multiple spondylolisthesis in multiple sites, then it would span several codes. They don't want you to list all the different codes. They want you to pick the M43.19, which has multiple sites, and then your documentation could reflect the specific areas. All right, that's just a guideline. Okay, I think I have one more guideline. And by the way, none of these guidelines are actually in the quiz. The quiz questions you get, there are 5 quiz questions for your C credits. They're all based upon the rest of the presentation, okay? I just wanted to get some of these out there for you. So yeah, this is the last guideline I want to share with you. On chapter 19, which are your S codes, we are told to code the most serious injury first and do not code superficial injuries with more serious injuries at the same site. So an example would be a contusion. If you coded, I mean, you wouldn't typically code for like a broken rib, but there's no reason if they have trauma to also code for bruises over that rib if it was relevant. So those are just a few guidelines that I felt might be relevant for musculoskeletal diagnoses that you might find helpful. And now I'm going to shift into my top 7 conditions for chiropractors. Okay, and I'm just going to let you know right now that my first quiz question for you is about sprains and strains. Okay, and I haven't got the answer's not on this screen, so when I get to the answer, I'll point it out to you. So the first quiz question will be about this. What I've done here is I've taken a list of all the most common sprains and strain codes I think chiros will use. These are all spinal, so I know you might do some extra spinal, but I want to go with the most common. And you can see here that we have strains and sprains for the neck and up cervical spine, the thoracic, the lumbars. And then, one common issue we run into is there really isn't a sprain code for the pelvis, but we do have a strain, and that's just the way the codes are. And then on the right column, I've got kind of a description of what it is, stretching or tearing of ligaments or muscles, depending whether it's a sprain or a strain. So I think most of you are familiar with these and the difference between them, but here's the group of codes I think you're most likely to need. And if I were you, I would make sure all of these codes with the 7th character added are listed in your codes list in PayDC for you to choose from. Okay, and again, if you don't know how to do that, call support and we'll walk you through that. So what I did was I looked at those codes in the coding book, in the official ICD-10 code list, and these are the things I learn when I look at the code book, what the code book teaches me about those codes. For one, they commonly occur together, but they must be coded separately. So it's not okay to just code for one of them and say that, but it's implied they have the other one. In ICD-9, you may remember that there was only one code that included both sprains and strains, and they got separated out into ICD-10. And so that is what the quiz question is about. Just so you know, it's how do you code for sprains and strains? And it says, well, you code for each one. That's the answer. Okay, so I'm just telling you that now. So in half an hour or 40 minutes when you do the quiz after this is over, that's the answer. Sprains and strains each have their own code. Okay, there's no combo code that puts them together. You can't ignore one. You got to do them both if the patient has both. The seventh character A, the initial encounter, is the most likely choice for these codes as long as the patient is undergoing active treatment. If you would like more information on that, watch the last webinar. Again, it's posted on our website. If you just go to PayDC.com, in the top corner it says watch our most recent videos, and I think it's the top one because it's the most recent one we did a few weeks ago to talk about the seventh character. But I believe that when you're treating a patient actively, then you should use the A because its definition includes active treatment. When it comes to extremities, I didn't list the codes on the previous screen, but they follow a similar pattern. They all begin with the letter S. The second character tells the anatomic location. So for example, S6 is for the wrist, S9 is for the ankle. And the third character is for this, designates whether it's a sprain or a strain. It's typically a 3 for sprains, a 6 or a 9 for strains. You don't have to memorize any of that. That's not that. I just want you to see that there's patterns and there's logic behind ICD-10. Okay. And then when it comes to symptoms, I believe that it would be inappropriate to code for pain in an area where you just coded for like strain of a muscle. There's no reason to say you also have myalgia where there's strain of a muscle because that's a given. Just like that guideline we saw earlier, don't code for symptoms if you have a more definitive diagnosis that already captures that, okay? So for sprains and strains also, if I were to audit your records, I would hope that you had these things documented. If you diagnose a patient with a sprain, here's examples of things that I think you could use to justify that diagnosis. You palpated the patient. You found pain with passive assisted motion. You did flexion extension, residual motion x-rays, maybe an MRI. For a strain, I would expect palpation and pain during muscle contraction because, again, I talked about this in the last webinar a bit. Strains include muscle movement and sprains do not because sprains are dealing with tissues that don't contract with ligaments. And so these are ways you could differentiate between these two things in your notes, in your records. Okay, so if you don't have any palpation documented, but you coded a patient with a sprain, I would get, if you didn't document any of these details, but you diagnosed them with a sprain or strain, I would challenge you and ask you to show me where your records support those diagnoses. All right. What about the proper CPT codes? What are the best CPT codes for sprains and strains? Well, this is all just my opinion, by the way, but if you code for a sprain and strain, I think it could make sense to perform some types of manual therapy because you're helping realign the tissues or whatnot, break up adhesions that are more of a long-term result. Massage therapy to help the soft tissue heal, therapeutic exercise to help realign the fibers. And then for the pain management, electric muscle stimulation, mechanical traction, ultrasound, hot and cold pack. I think those are good procedures to link to a sprain and strain. You'll notice here that I did not include the CMT codes, the chiropractic adjustments. And you might disagree with me, and that's totally fine. In my clinical opinion as a chiropractor, I don't think I can justify doing an adjustment on an area that has a sprain because to me, that's a contraindication. So if I want to also manipulate a patient, I would link it to a different diagnosis. My favorite, of course, is M990. I think that I can adjust a patient who's had a sprain, but I wouldn't explain the sprain as the cause of why I'm doing the adjustment. And that's just my opinion. So that's kind of where I would go with that. Let me field a couple of questions here. Here's one from Dr. Sherman. It says, if the myalgia is a separate region from the strain, you still use it? And the answer to that is yes. I'm going to talk about myalgia here later in the presentation a little bit. So I'm just saying there's no reason to say they have myalgia in their neck if you already said they have, a muscle condition. And Dr. McClatchy, let's see, for multiple sites codes, what are we supposed to do if that is all we are finding in that region, since we're supposed to have them paired with the M990? Yeah, so that's correct. If the multiple sites is only an option with a handful of codes, like the one I showed you with stenosis, so it doesn't apply most of the time, and so that's fine. You don't need to worry about it. I hope that answered your question. I can come back to that one a little bit later on, because I think you gave me some other details there that we can talk about. So I have one more thing to talk about with sprains and strains, and this is just an example of some notes that I think capture the necessary information to support this diagnosis. If I diagnose the patient with sprain of ligaments of the cervical spine, I've listed here some subjective and objective findings that I believe would support this and stand up, to a peer reviewer, basically. who wanted to go in and say, hey, you use this diagnosis, but your notes don't support it. So I basically put in stuff here that I told you in the previous slides you needed. Rather than take the time to read this to you and discuss it more thoroughly, I am going to just move on and let you know the screen is here, and you can come back on the recording and you can access this and take a look at it. So I want to go to the next condition. Okay, those were the 5 things I wanted to cover for sprains and strains. Now I'm going to cover those 5 things for segmental dysfunction. These are actually the most common codes we use. So the first thing I want to look at is what are the code choices or the options in the ICD-10 book for segmental dysfunction? Well, you got your M990s, right? And they're separated by different regions of the body, so you can see here which regions they are. That's fine. So what do we learn if we look at these codes in the code book and we look at the guidelines and the things right there in the tabular list? Well, one thing we should note is the word subluxation, okay? There are other ICD-10 codes that include the word subluxation, but it appears that they are not recognized as payers as indications to justify chiropractic manipulative treatment. So I would encourage you to consider documenting, if you want to, segmental dysfunction to match the code description. You'll notice that in PayDC, the notes don't automatically say subluxation. We don't use that phrase in there. It's not a phrase that aligns well with ICD-10 for the codes that justify chiropractic manipulation. And then you look at those traumatic subluxation codes, and I have them grouped here, S131 for cervical, S231 for thoracic, and 331 for lumbar. Those have the word subluxation in them, and you might get excited about using them, but they also include, if you look at the inclusion notes, they include sprains. And so you wouldn't want to report those along with sprains if someone has them because they're included there, and you have to kind of look at the codes and their definitions to understand that. I believe that PART is one of the best ways to document the justification for an M990 diagnosis. PART is Medicare's guidance on information. So if you capture 2 of the 4 of the elements of PART, which is pain, asymmetry, range of motion, and tissue, then I believe you justified the existence of an M990, which justifies your manipulation. And so it's really easy to capture a couple of those. More details on that we can talk about separately as well. I want to get into these diagnoses more heavily. So the objective findings I expect to see would include static palpation, motion palpation, observation of the patient, like posture, range of motion measurements, and X-ray imaging. I think those are all great ways to justify segmental dysfunction, which again, in turn, justifies chiropractic manipulation. And so, therefore, these codes, to me, make the most sense to be linked to your chiropractic manipulative treatment procedures, 98940 to 9943. If you think that you can use M990 to justify other services, that may be true too. These are just the ones I think are the best match, right? I think that M990s are great for these, and you can use other diagnoses to justify other services, and we'll go through those as we continue through this presentation. So the final thing then for segmental dysfunction is I have an example here of some broken apart findings in some notes so you can really see examples of things that might support an M990-3 diagnosis. My subjective findings, well, pain, right? I don't really know of many other subjective findings that support segmental dysfunction, but I've listed examples of each element of PART so you can see what might count towards each of those in the objective findings. So there's some pain when they palpate it. There's asymmetry that I've documented. There's range of motion problems, and there's some tissue or tone problems. So you don't have to have all 4 of those there in every note for every M990, but you got to have 2 for Medicare, and one of them needs to be the A or the R. Again, I'm kind of brushing over this. It would take a little longer to discuss PART in a little more detail, but that's just one way you can capture that information. Okay. So just so you know, the second quiz question you'll be asked is a good way to make sure documentation of a chiropractic subluxation is tied to M990 is to do what? And I'm trying to remember what the answers are. And I'll tell you that the answer is, to use the word segmental dysfunction somewhere. Consider doing that. And you'll find that that will make it easy for a reviewer to tie it in if you want to use the word segmental dysfunction somewhere. I think that by default we use fixation in the records, but that's another way to look at it. Let me back up here. Question from Dr. Aaron about what's a good diagnosis code for whiplash? He said some insurances are saying sprain is too minor. Sprain isn't serious enough to diagnose whiplash. I have no idea, actually, Doc. I think that sprain and strain are the best ones for whiplash injuries. I'm not a PI expert though, and so I know that that I have some friends who are, and who I might refer you over to if you like some references, some consultants who do that work. But I know that there's a lot of good work being done right now with head injuries and concussions as it relates to car accidents, and so there's some things you could do there. And what was the other thing I was thinking of? Well, there's some other presentations you can find out there about Colossus and listing diagnoses that go beyond the ones required for billing. Let's see here. From Dr. Staten, he said, sprain strain on a re-exam. If I don't find the same findings anymore for sprain strain, update the diagnosis accordingly. Do I keep it as an injury in the patient's account? So here's what I think you should do. Let's say you've got a patient, you've been treating them for 8 weeks. You think they still need some treatment for something, but you don't believe they have a sprain or strain. You think that's resolved. I think you should, my opinion is you should leave it on the claim, but change the 7th character to D instead of A. A means it's under active treatment. D means it's now just kind of there and it explains the other things you're still treating. Contact me again directly if you want me to explain more about that. I talked about it in the last month's webinar as well, and you can watch that recording. But that's how I would handle that situation. That's a good question. So the next condition here that I want to look at is muscles. So muscles is kind of a broad category, but what I tried to do is capture the diagnosis codes I think you're most likely to need if a patient has a muscle problem. So I've listed, 6 different groups of codes here. You'll notice the first one, M60.8, is for myositis. M624 is contracture. M628 are weakness and spasms. And then the M79s I put in here are just 2 of them. I put in myalgia and fibromyalgia. So if you look here on the right, what I did was I listed examples. And basically how I came up with these examples was I Googled them. I was trying to come up with good descriptive terms that were unambiguous for differentiating these things. Because what I have found when I have done audits for doctors is they blur the lines between spasms and contractures, or between myositis and myofascial pain syndrome. And so I think that you should go out of your way to try to make sure your notes are clear on how these things are different if you're using each of these codes. So for example, you do myositis, and I believe that myositis means you need to state there's some inflammation, right? I choose other myositis because there are 3 other myositis conditions in the code set, but they do not reflect the kinds of things chiropractors do. So I left them out, and I think that you should use this M60.8, which is other, to make it clear that you're just treating inflammation of the muscles due to some trauma or something. And contracture is shortening or hardening of a muscle as opposed to an involuntary muscle contraction for spasms. And I think it's very important to distinguish that if you're using those 2 diagnosis codes. Okay, I think of a contracture as more chronic and a muscle spasm as a bit more acute or subacute. But again, that's just my clinical opinion. You don't have to agree with me there. You may feel that you can describe it differently or it plays a different role. But these examples, again, are not absolute. These are just, I literally used Google to come up with these. So that's my authority on this. And then fibromyalgia, again, just if you do use that diagnosis, just note that it's more complicated than simply muscle pain, and make sure you documented the other elements of that if you feel comfortable using that diagnosis code. So let's dive into what the code set teaches us about these codes. If I were to open up the code book and read up on these codes and look at the guidelines and compare it to the codes around it, here's what I might learn. For myositis, you can see here that I would expect you to do other signs of inflammation, which might include heat, redness, or swelling. As I mentioned, the other subcategories are infective myositis, interstitial myositis, and foreign body granuloma. I don't really think chiros are using those. I don't think you should, probably, or maybe if you feel like the patient has those. So that's why I chose other, which is the 8 is the 4th character when it's the other category, meaning it's not infective or interstitial or foreign body. And the 5th character for this, when you look it up in the code set, is the anatomic location, okay? If you do contracture, just so you know, the 5th and 6th characters describe the anatomic location. So I didn't give you that much detail. And with weakness, when we look it up in the code set, we see that M6281 has the word generalized in its description. Does that mean the patient has to have weakness generalized over their entire body? Well, it doesn't, because it's in parentheses and it's a non-essential modifier. Anything in parentheses is considered non-essential, so it's not a required part of the code. So if you have a patient with weak neck muscles, this would be the correct code to use. It doesn't have to be everywhere in their body. That's what I'm trying to say there. And for spasms, when we look that one up, we learn that the 6th character describes the location. I wish they had more options here, but all we have is back, calf, or other. And in my opinion, back only goes up to T1. If they have muscle spasm above that, I think that's the neck. And for me, I count that as other. If you think the neck is part of the back, then go ahead and use that code. The code set doesn't explain it, and that's just my opinion, okay? Myalgia, when we look this code up in the diagnosis, in the code set, we learn that if you code someone with fibromyalgia or myositis, you don't also code myalgia. The codes specifically are exclusion in there. It says if you code with myositis or fibromyalgia, you may not also code myalgia because it's already included in those conditions, okay? So those are the coding considerations, the things I learned when I look up these codes in the code set and what it teaches me when I see them in the tabular list. If you believe you can use one of those diagnoses on your claim, I think that your notes should contain objective findings like these. Muscle strength should be tested for a lot of these codes. Palpation for sure, that's probably the number one. You need to palpate the muscles and say what you found. And then algometry is another one to consider. For those who may be unfamiliar with it, that's pain thresholds, you know, essential for fibromyalgia diagnoses, but you can use that pain thresholds with algometers that can be a helpful objective finding. There may be other objective findings you think are relevant for muscles. I guess I could have put in range of motion things that could relate as well, but just the point is you need to have objective findings if you want to throw in a diagnosis code. So these are the procedures that I think make sense with these diagnoses, okay? And you may disagree with me, and that's totally fine. I'm just giving you some examples that I came up with, and we can discuss these if you wish. I think that 97140 goes really well with M791 and M62.4. That is, I forget, M791 and M62.4. Remind myself, M62.4 is contracture, and M791 is that myofascial pain syndrome. Yep. So I think that contractures may justify manual therapy, and myofascial pain syndrome, which is synonymous with trigger points. Massage therapy matches well with spasms and contractures. Those are the two codes I listed there. Neuromuscular reeducation is a bit more of a stretch, but you can do M6281, which shows generalized muscle weakness, meaning I need to retrain the muscles because there's been damage to them and they don't work as well. I got to teach them how to work again. That may be a diagnosis you could relate to that. Although I should warn you that 97112, neuromuscular reeducation, requires other things and it's a little bit more strict than other codes, and you need to be aware of that. And I'm sure we've talked about that in the webinar I did. Oh, the webinar I did for ChiroCode last month. And if you need to know where to find that, I can, email me and I'll send you the link. And then I've listed 4 modality codes there that tie into soft tissue stuff, can help with spasm or soft tissue pain. So those are listed there as ones I think could be tied directly to a M62 or M79 diagnosis for muscle problems. Okay. I did get a question a few minutes ago from Paul. He says 97140 is getting denied as only for PTs. Paul, I can tell you that if that is the reason they're giving you, they can't do that. The code book itself, the CPT guidelines say that you can't, the codes are not for only certain professions. The 97140 is not only for physical therapists. Any practitioner who has a license and it's in their state scope can do it. If a payer's denying it, you have a case to argue against them. And, I can help you more with that if you want to contact me afterwards. But 97140 is getting scrutinized more heavily than ever by payers because some chiropractors didn't bill it properly in the past and still may not, and our payers are just getting almost unreasonable in how often and easily they'll deny that code. So here's an example of some sample documentation for muscle spasm of the back, which is M62830. I've got subjective complaints that support a muscle spasm, hard, tight muscles, and then I got a history here that kind of lines up with someone who might have this problem. This guy went out and played these 36 holes of golf, and he usually doesn't golf very much, so now his muscles are really freaking out. And then I've got some objective findings that support this. Palpation shows tight, rigid fibers, range of motion is limited. Consider an X-ray. Look for some other cause of limited range of motion. So those, I believe, are subjective and objective findings that would support the existence of this diagnosis on a claim. All right. So that's my muscle conditions. I've now moved on to disc disorders, and I know that I'm going fast. through this. And so I apologize a little bit, but we are recording this and it'll be available for you to rewatch, and you can, fast forward through it and whatnot within a few days. Before I go on though, I did have a quiz question about the muscle stuff. And the quiz question is, why are codes like massage therapy and ultrasound linked to diagnoses like spasms and contractures? And the answer is because they're clinically valid. The reason I'm telling you these diagnoses tie in is because clinically, soft tissue injuries and massage go really well together. That's why I'm suggesting you should link things like soft tissue diagnoses, muscle issues to procedure codes that involve working on the soft tissues, because they're clinically valid. There's a link between them. And I can show you at the end of the webinar here to make sure you guys understand in SOAP notes how you can do your diagnosis code linkage, but you should be doing that. Don't always assume all your procedures and all your diagnoses go together. You should specifically point to certain diagnoses for certain procedures. That's kind of one of the reasons I'm sharing this with you today. So that is another quiz question. The answer is, the reason I do these procedures with these diagnoses is because they're clinically valid. They tie it together, okay? So here are the disc injury diagnoses, the disc disorders rather, and the ones that we're going to use come from M50 and M51. The M50 diagnoses are cervical, and the M51s are thoracic and lumbar, all the way down to lumbosacral. And then you'll notice that for these codes, the fourth characters are almost the same in both of these two boxes, but there's one extra one in the lower box. That's for Schmorl's nodes, M51.4 towards the bottom, because you don't get Schmorl's nodes in the cervical spine because of the existence of uncinate processes. It just doesn't happen there. So that is one that's additional. But if you look at the rest of the fourth characters, are exactly the same, whether you're in the cervical or the thoracics or lumbars. Like for example, M51.3 is degeneration, and M50.3 is also degeneration. Okay, and I've listed examples of how these differ from each other here in the far right column. I just want to point out things like the only time I'd use M50.2 is if I had something that would have been the same as M500 or M501, which is myelopathy and radiculopathy. So there is a disc, but I don't have a neurologic thing. If I had a neurologic thing, then I would use M500 or M501. If it's, I hope that makes sense. Degeneration for me, that means I took an x-ray and I saw degeneration. But there aren't neurological things. If there were, then I would find another code that listed out what those neurological things are, And M508 or M518, which are other disc disorders, I would only use those when I can't find any other disc disorder that makes more sense, And M519 and M509 for unspecified disc disorders, I would only use that if none of the others made sense. You never use that until it's the only thing you have left, okay? So if I were to go into the code book and look up all these codes and try to see what I can learn from them, here's what I'd find. The fifth character for all these codes designates specific anatomic locations, so you can look those up. And then when it comes to symptom codes, we have these guidelines that let us know that codes like cervicalgia should not be coded along with M50s. If you coded a patient with cervical disc disorders, the guidelines tell us you don't also code for cervicalgia. Now, you and I might say, well, a patient could have a cervical disc problem without neck pain, but the guidelines say not to do it. Similarly, low back pain should not be coded along with other disc displacement in the low back, M51.2. Also, radiculopathy should not be coded with the codes that include radiculopathy in their description, because that would be saying radiculopathy twice, and that would be ridiculous. Ridiculopoulos. Okay, that was a bad pun, but I was trying. Sciatica should not be coded with M511 because they believe it's already included, sciatica and disc disorder with radiculopathy. Those are just pulled out of the guidelines for those codes. And if you're ignoring those guidelines and you're coding these things together, your claims could get denied. Okay, that's why it's important for you to know the code set, understand how the coding rules work, look up the codes you're using, and make sure you don't use codes that are not compatible with each other. But rest assured that in this presentation, I've captured the most important ones. So if you just need to make sure you're not missing anything, I've got pretty much everything you need to remember in these slides, and you can just, again, go back to the recording and make sure that you've got your code set up properly. If you had a patient with a disc disorder and you had notes, and I audited your notes to see if you could really diagnose them with that, I would expect to see a bunch of neurologic tests and maybe some advanced imaging. Okay, that's pretty much all I could come up with objectively that I felt you could do to justify the existence of a disc. Orthopedic tests, neurologic tests, and then advanced imaging diagnostic testing. If you think you can diagnose someone with a disc injury without these things, then go right ahead. Just be prepared to defend yourself against a peer reviewer, okay? And then what are the procedures I think you can use along with these diagnoses? Well, they all involve separating joint spaces or pulling things apart. So I chose the procedures of chiropractic manipulation because you're moving joints, manual therapy because it includes manual traction, and mechanical traction. I think that you can justify these services for a patient with a disc disorder. You might think there are other procedures you could do that could be justified by disc disorders. I don't know what those are. These are the ones I came up with again. So I'm just offering my opinion here. If you do other procedures, tie them to different diagnoses. You know, that's kind of what I'm trying to say is do some diagnosis pointing and make sure that your procedures and your diagnoses relate to each other and they're clinically relevant, okay? Here's an example of some documentation that I think supports M50.122, which is cervical disc disorder at C5, C6 level with radiculopathy. And I'm not going to read this to you. I just want you to know I came up with some subjective findings and objective findings that I think any peer reviewer would go, yep, that's definitely a cervical disc disorder with radiculopathy. You know, and that's what I've tried to do here. So the next group of conditions that I wanted to look at was pain and stiffness. Okay, and these are not my favorites. You know, we talked briefly before about a bunch of codes that start with the letter R from the chapter in ICD-10 that cover symptoms and signs. But here are some pain and stiffness codes from chapter 13 that start with the letter M. These are all symptoms, right? These are not definitive diagnoses. These are, for the most part, restatements of patients' subjective complaints. So you can see here I've got some extra spinal ones there, M25s, and that M79 is also an extra spinal. And the ones that are bolded there are M54s, those are spinal. The reason they're bolded is because they're complete codes with all the characters they need. The other codes here have a hyphen, meaning you need to add a fifth or possibly a sixth character. So let's take a look a little deeper here at what we find out about these codes when we go to a code set. Now, I'm sorry there are so many words on this slide, but I don't know, that's just how I set it up. Basically, what I did was, again, I looked through all these codes that I just showed you that are good pain codes for chiropractors to consider and use. And I looked through the code set, and I came up with these things that I learned from looking at the codes, okay? My first bullet there is one I talked about in the webinar last month as well, and that is, if all you have is a patient's complaint, then that's the diagnosis you use. But if you have anything better than that, like a definitive diagnosis, then please use a definitive diagnosis because it's much more able to justify medical necessity, okay? And then I have a statement here, the second bullet. A lot of conditions like strains with muscles include pain. So signs and symptoms that are routinely associated with a condition should not be assigned as additional codes. That's almost a quote, word for word from the guidelines, okay? And as I mentioned a moment ago, some of the disc disorder codes specifically exclude spinal pain as being listed together. You can't do it. Now, there are codes for joint stiffness. If I go back one slide, the joint stiffness codes are M25.6, right? Stiffness of a joint, M256. But there are no codes for spinal stiffness. So if you want to just say their spine is stiff, I think the best way to do that is to include it as support for your diagnosis of an M990, which is segmental dysfunction. So, because I've had people contact me before, well, I see that there's a code for elbow stiffness. Where's the one for, you know, cervical spine stiffness? There isn't, but you can say segmental dysfunction. And I think that spinal stiffness is an attribute of segmental dysfunction, you know, one of the elements of part, as we discussed before. What about the extra spinal pain and stiffness codes? Well, the 5th and 6th characters are there for your anatomic location, okay? And for whatever reason, the fingers and the toes are found in M796. And if you don't know what the causes of the stiffness, the very last bullet here on your screen, stiffness of a joint, NEC, you only use that code if you don't know what's causing the stiffness. If we look up the codes for ankylosis or contracture of joints, which is M246 and M245, they specifically have an exclusion note underneath them that says do not code for stiffness in these joints, because it's a given. We know they have a stiff joint if they have ankylosis or contracture, okay? That's taken straight from the guidelines. That's just me looking up the guidelines in the book. So if you wanted to use a pain or stiffness diagnosis, I would expect your objective findings to have things like palpation and range of motion. I really don't know what else you can do. And I frankly don't think that those codes require much objective notes because they're not even a diagnosis of a condition. They're just a restatement of symptoms. So I believe that those codes really only support a few procedures. And all I've listed here are 3 modality codes. I really don't think that you can use pain. You can use stiffness to justify some, I guess, some traction perhaps. But for the most part, pain codes are really only good if they're tied to procedures that help manage pain. And I've seen doctors try to justify the chiropractic adjustment based upon a stiffness code or just a pain code alone. And I don't think that's enough. I think you need to go ahead and go to an M990 because it's better. Right? That's my opinion. And that's Medicare's opinion too. So we're in agreement on that one. So if I were to look up your notes, I want to see how you would describe one of these conditions. If you diagnose the patient with M541, which is cervicalgia, the subjective might read like this. You know, patient says their neck hurts. Okay, but nothing else. I really don't have much more. I don't have radiation. I don't have any crazy findings. It's not that extreme, because if it was, I'd come up with a better diagnosis than just cervicalgia. In the objective findings, I have very little to say. If I had more to say, I'd find a better diagnosis. So all I have here is some postural stuff and some muscles that are a little bit, you know, tender, and range of motion is a little bit limited. X-rays don't show anything like degeneration or anything more interesting. So that's the documentation for cervicalgia, very basic. It's basically saying the patient told me they hurt and I have no other findings, you know, or very little. Okay. So that brings us to the next condition, which is radiculopathy. I think if my math is right, I have 2 more to go through with you guys, maybe 3. 2 more, I think. 2 more conditions. The next one is radiculopathy codes. Okay. Radiculopathy and sciatica, which are separate codes, but we have to make sure we understand the difference. And the next quiz question is about radiculopathy. Okay, so I'll give you the answer as soon as I see it here on the screen, so you know. Here's an interesting comment though about stiffness codes or pain codes. Dr. Kuna says, didn't Edna link the stiffness or pain codes to 97140? I don't know, and that's an interesting point. If you have if you've been told by Aetna that you can get paid to do 97140 for stiffness or pain codes, then that may work. I think that you can make an argument there. And as I think about it, I might add that into my presentation here. I think if you said someone has stiff joint, you could justify 97140 if you're doing traction on it. That makes sense to me. So yeah, go for it. I mean, again, my rule here is not absolute. I'm just giving you my opinion as a chiropractor / auditor coder, okay? Now, let's take a look at these codes here. That was a good question. I just got 3 groups of codes, M541, 3, and 4. And I tried to differentiate between the differences between radiculopathy and sciatica, because I'll be honest with you, I remember when ICD-10 came out and I was trying to understand these codes, I frankly didn't feel like there was a difference between sciatica and radiculopathy. I thought they were synonyms. But as I researched it, I determined that the most clear distinction is that the sciatica follows the path of the sciatic nerve, whereas radiculopathy follows the path of a nerve root, which may be different. Also note that at the bottom of your screen, I've got 3 more diagnoses that are other conditions that are more definitive that explain the radiculopathy. So I've got a disc disorder for the cervical or the thoracic and lumbar, and then spondylosis that includes radiculopathy. So if you have a patient with one of the conditions at the bottom of your screen here, then don't code for radiculopathy separately, right? So if we go and look up all these codes here in the book, here's what we learn, okay? I tried to figure out a definition. So remember that the code for radiculopathy also includes neuritis and radiculitis. So if you really want to differentiate between those, you don't need to for coding purposes. You should in your notes, but I looked it up, and here's how those 3, so the first 3 bullets here are defining neuritis, radiculitis, and radiculopathy. Okay, and I've listed here what I think might be ways to justify those particular terms. But for coding purposes, it doesn't matter which of those you think your patient has. They all have the same code. It's M541, okay? And then for sciatica, I found varying definitions that sound a lot more like radiculopathy and they sound the same, but my best distinction is that sciatica travels down the butt and the path of sciatic nerve down the back of the leg instead of wrapping around like a nerve root typically would, okay? So, laterality. Interestingly enough, radiculopathy, you can't report laterality with that code. It's not an option, so document it for sure if you have radiculopathy down one leg and not the other, or one arm and not the other. But note that the code doesn't specify laterality. However, sciatica does. So when you code for sciatica, you do specify laterality. And remember that if you use a combo code, lumbago with sciatica, it's inappropriate to do sciatica separately and lumbago separately. You should use the combo code if it's available. And there's a code that includes lumbago and sciatica, so you should use it if that's what your patient has, okay? So question came in here from Dr. McClatchy again. He says, to clarify, when you say stiffness diagnosis isn't enough, you're saying you need to have M990 code with it? You're seeing people use it without the M990 code? Yeah, I am. That's what I'm saying. I've seen claims, I've done chart reviews for doctors who don't diagnose M990, but provide an adjustment. And I think you should always do an M990 when there's an adjustment. I really think that's always justified in the chiropractic case. Now, could you add a stiffness code for a secondary? I guess so. You know, it kind of works, but it's not a great one just because stiffness is only a symptom, and I don't like it that much. It'd be better to find a more definitive diagnosis to pair with the M990, in my opinion. So I hope that answers your question. So what should you document? If I was your peer reviewer and I looked at your records and you used the diagnosis of radiculopathy, what would I expect to see? Well, neurologic tests, orthopedic tests, possibly advanced imaging to look for a cause of the radiculopathy, like a disc or a foreign object or something. So the quiz question is, before you can diagnose a patient with radiculopathy, which of the following objective findings should be documented? And I've listed a bunch of the tests from here and all of these as an answer. So the answer is all of these, okay? When you ask quiz questions like, what kind of things should you look for? What I expect to see in your notes, you know, could be something documented for radiculopathy, and it's anything you see on the screen right now, okay? So the quiz question is an all of these answer. So what are some good procedures that you can tie to radiculopathy? Well, the same ones I listed before, because radiculopathy implies that there's a nerve being compressed or pinched somehow. So I've listed procedure codes that decompress things, that pull things apart or move joint spaces apart. So I've chosen these 3 procedure codes. They're not the only ones, but they're the ones I picked because they seem the most obvious to me. All right. Okay, so that's the quiz. Let's see here. I've got one more condition I think to go over with you. Oh, I'm not quite done with this one though. Sample documentation for radiculopathy. So I've got a bunch of stuff in here, but I don't have anything to make it more definitive, like to explain that the radiculopathy is due to spondylosis or a disc. But I've got subjective findings that are very consistent with classic radiculopathy, and it follows the path in the objective findings of a nerve root, not the path of the sciatic nerve, okay? And I did a few orthopedic tests. You know, I've got some muscle strength issues. I got a reflex that's lost. Great neurologic findings to support this diagnosis, okay? Yeah, so I think headaches, I think this is my last condition for you guys that we're gonna go through. And my last quiz question is is about headaches, okay? And it's not like, hey, you know, what causes headaches? Well, listening to Dr. Williams' webinars, right? That would be very nice to me. But I might say something like that. Let's go through headaches. Headaches are a little bit harder and a little more obscure because they don't have much in the way of objective findings, right? They're very subjective. There are 2 categories of headaches in the code set. So I pulled up on this table you see on your screen now, the most common headache codes I think chiropractors are likely to need. I've left out just a few, but I've got the migraines and other headaches. G44 is migraines and G43 is migraines and G44 is other. Okay, and so one way to simplify that is G43 is migraines and G44 is everything besides migraine. And that is indeed how the code set is set up. And then in the column on the right, I've listed examples of each, and I used Google to help me come up with good descriptors because I think some of us use these terms interchangeably when we shouldn't. For example, the definition of an aura, or what makes one of these chronic, right? Well, according to the National Headache Society, or I forget who the agency was I found this at, a chronic headache is 15 or more days per month for at least 3 months. That's kind of how it's defined. And if your patient says, "Man, I've had this headache for 2 weeks," I don't think you can call it chronic yet, okay? If they've had it at least 2 weeks over 3 months, yeah. So that's a little things to be aware of, okay? Also, if you look at post-traumatic headache, G44.3, I don't think you can use that routinely with everybody who's been in a car accident. They have a headache. I think it needs to be someone who you also report some sort of brain injury like a concussion. That's my opinion. You may differ, that's fine, but I think that you're safer using G443 following a trauma if they've all had some sort of literally a trauma to their head like a concussion, okay? So it's just a bunch of codes. Let's take a look at what we learned when we look them up in the code set. For most headache codes, the 5th or 6th character identifies whether or not the headache is intractable. So ICD-10 does not include definitions. There is no there's no glossary. But in this case, there is. It actually says definition of intractable right in the code book. It says it's pharmacoresistant, treatment-resistant, refractory, or poorly controlled. And so just keep that in mind if you're going to use that phrase, intractable. And then R51 is another code that I kind of brushed over that has headache in its description, but it's a symptom code, and it's the one we use when you don't know what the headache is. You just know their head hurts, okay? And that's what the quiz question is. It's when to use R51. It's when you don't have a better diagnosis, all right? Gosh, I just saw the time. It's the top of the hour. I need to wrap this up and make sure you guys have what you need. So these are the objective findings. There's nothing really for headaches except for imaging to look for tumors. And as far as procedure codes, I'm not sure if there are any good procedures that tie to headaches. You know, maybe adjustments. I don't know what else. All right. So here's an example of some documentation I think that could support the diagnosis of this particular headache code. So I've matched the description for intractable and chronic in these descriptors. And I've made sure that I've got all the details here as an example. You guys can go back and watch this recording. I'm really sorry I hit the top of the hour. So what I've just done with you is I went through 7 different conditions. I did some guidelines first, but we went through these 5 things for each condition. So you get some ideas and some details there. I will happily stay on here for a few minutes to answer your questions. And so I want to stick around, but I want to respect those that are out of time or have an appointment at the top of the hour. So I'll stick around. I can stay for 5 or 10 more minutes if you'd like. If you guys want to keep sending questions in and we can talk. I'm also happy to take emails from those of you who are clients for the most part. If you're not our client, by the way, please contact me and I'll do a demo of the software for you. And I'll show you how you can become a client and how we can help you get better records. That's my email address right there. So feel free to reach out to me. Those of you who have some pretty specific questions and you want to bug me, we can talk some more. I'm happy to help. That's my role as a clinical director for PayDC, is to help you guys get better notes, have them be more clinically relevant, you know, make sure that we're giving you the best service we can. So feel free to reach out to me at any time. So a couple things. I'm going to answer some more questions that have come in, but you're going to get a quiz in a few moments as soon as this ends, and I think you'll get sent a link an hour later as well. So answer that promptly because the answers will be easier for you. You know, if you miss one, it's no big deal. If you miss all of them, that'll mean you didn't listen. So I'll bug you about that. And you won't get the credit hours maybe. So just make sure you do the quiz if you want to get your credits. And you just note that you will be charged $10 after we get the attendance report in, and we'll charge you $10 to help cover the cost of getting you the credit hours. Just so you know, and if you're not a client, you can not have to pay if you set up a demo. So please set up a demo and we'll show you the software and get you going. Let's see here. Let me go back to some of these questions and feel free to shoot some more in. Otherwise, you guys are more or less free to go. I've given you everything you need to answer the quiz. I hope this was helpful to you. I should let you know though, one other thing. I want to do a webinar. I'm hoping in the next 4 weeks or so, where I'm going to do a deep dive into the software, into the settings for documentation issues. I'm going to help you with some lists and things in the settings to really maximize your experience with PayDC and help you streamline it, get faster, quicker, complete notes. It's not going to be for CE credits because it's going to be very much focused on our product. And I've got a 5 or 6 page handout I'm planning to prepare for that. So watch for an announcement on that. I'm hoping you guys will find that to be really helpful to help you get even more out of this. Question here from Vincent says, any reason you did not include the Therex codes for any of the spinal conditions, like 97110, 97530? Yeah, so Vincent, I think that if you do like 97110, which is therapeutic exercises, that you need to show, well, let's see. I mean, I don't think that would tie in for, let me show you some examples here. Like therapeutic exercises, I don't think that makes any sense with headaches, for sure. Let me go back here a little further. Radiculopathy, I guess you could do exercises for radiculopathy, but for me, it's more about soft tissue injuries, sprains and strains. You're repairing the tissues. You're retraining the muscles or the nerves. So I guess you could tie it into this. Yeah, and same thing with the discs. So yeah, you can make an argument there. See, again, I'm flexible here. You guys, this is just my clinical opinion. You're gonna have your own, and you can talk to me and we can come up with some things. As long as you can justify it, feel free to do it. And then Blair asked if we could print off this information today in the PowerPoint. Email me if you'd like me to send you a copy of the PowerPoint. I typically don't provide them, but you guys are clients, so we'll help you out. And the recording is available for you, of course. It'll be posted on the website within the next day or two. And you can watch the recording, okay? And Dr. DeFabio is saying, hey, we need to do a PayDC specific end user documentation session. And we're doing it within the next 4 weeks. I'm hoping to have that up for you. We're going to dive into the software, and I'm going to have PowerPoint slides. We'll just in the software. I'll take the questions. We'll work on it. We did a user conference last month in New Jersey, which went really well. We'll probably do another one this fall or possibly next spring. And so we invite you to look into that when we announce it and have you guys come out. You can do it face-to-face with me and Dave Klein all day long, and our billing staff will be there. We'll really help you get the most out of your software, okay? You know what, that's the last question I think I didn't answer. There may be a couple there, and I apologize if I didn't get to your question. Feel free to email me again. Let me get back to my email here, and I'll let you guys get back to your day jobs. Thank you so much for being here with us, being our clients. We love you. We want to help you. We want to make this experience as smooth and fast for you as we can. We've got more coming, updates to the software, training to help you get better at it and use it in the way that it most benefits you. So thanks so much, and don't forget to do the quiz to get your credits. All right, you guys take care.